Good morning, everyone. Welcome to our COVID-19 webinar series presented by the Institute for Science and Policy, the Denver Museum of Nature and Science, and our partners, the Colorado School of Public Health. I'm Kristan Uhlenbrock, and I have been your host for this series. And we are coming in at episode 22, and I see so many familiar faces joining here on our live programming. So thank you for continuing to tune in, and great to see how useful this series has been for you. So a huge thank you to everyone who's put this together. As I mentioned, this is a partnership between the Colorado School of Public Health. So a huge thank you to John Samet and all of his colleagues, as well as my partners and colleagues at the museum and at the Institute for Science and Policy. So before we get started, just a few notes and reminders and housekeeping items. Nicole's been telling you to let us know where you're watching from in the chat. Feel free to continue to let us know where you're tuning in from. We see folks from all over Colorado and beyond, which is great. That's also going to be where you ask us your questions. We're going to hopefully have a good 20 minutes of Q&A after two presentations today. And so feel free to ask your questions throughout, and we'll try to queue all of those up as we get to our Q&A portion there at the end of today's presentation. It will be for about 45 minutes, so we should be done about 9:15 today. We also have an audience joining us on Facebook Live, so hello if you're on Facebook this morning. We want you to engage with us as well with your questions, and so feel free to use the comment feature. We've got staff monitoring all of that, and so hopefully we'll try to filter in all those questions for me at the end. And as you know, I do not get to all of them, but we do our best and try to incorporate and merge some of this together for some Q&A. Last episode 2 weeks ago was an open forum where we did literally take all of your questions and just put them to a panel of experts. So if you missed out on that, I encourage you to go back and check that recording. We also have a written recap. All that information is on the Institute website. That's institute.dmns.org. I also want to just give a quick reminder here at the top of the hour, a half hour, that we will be taking just a small break after today's episode. And we'll be coming back on December 14th for a kind of big end of year episode. One reason we're taking that break is that the Institute is hosting our annual symposium on December 1st and 3rd. And I'd love to invite, of course, all of you, as some of our wonderful guests here on the COVID episode, to join us for our symposium. It is a free virtual event on December 1st and 3rd. You can find information about it on the Institute website. But we're going to be talking challenges including health and climate and misinformation, and how does trust and science all come into play when it comes to policymaking. So I encourage you to join us for our symposium. So now what you tuned into on to today's episode. So we are going to be talking about COVID-19 and the flu. So here in Colorado, as well as around the US and other places, we are definitely heading into that third wave of COVID-19 outbreaks. We're also heading into the winter season here, and that means flu season. Both of these are highly contagious respiratory viruses. And so at the same time, how do we manage both COVID-19 and the flu, particularly in the Northern Hemisphere, whereas we're coming to our winter season? So there's going to be some similarities between the two. There's going to be some differences. We're going to hear a little bit of update on vaccines. We're going to put all of this into a really big context for you today. And we're going to talk a little bit about how do we prepare and mitigate against some of these challenges. So I have two wonderful experts joining me today to help us walk through the differences and the similarities between COVID-19 and the flu. We have Dr. Jon Andrus. Dr. Andrus is an adjunct professor and director of the Division of Vaccines and Immunization at the University of Colorado Center for Global Health. He is also an adjunct professor at George Washington University's Department of Global Health and at the Milken Institute of Public Health. Dr. Andrus leads efforts to advocate for evidence-based use of vaccines in developing countries. Over his 30-year career, he's held leadership positions in organizations such as the Pan American Health Organization, the World Health Organization, and the Institute for Global Health at the Universities of California, San Francisco, and Berkeley, among others. He has also received the Distinguished Service Medal, the U.S. Public Health Service's highest award. Also joining us today is Dr. Suchitra Rao. Dr. Rao is Associate Professor of Pediatrics and Infectious Diseases and Hospital Medicine at the University of Colorado School of Medicine, and the Associate Medical Director of Infection Control and Prevention at Children's Hospital, Colorado, where she leads the influenza vaccination program. Dr. Rao is a 5280 top doc, a national expert on influenza, and has spent the last 14 years studying respiratory viruses. She also collaborates with CDC, NIH, and a number of other national networks. She studies influenza epidemiology in children, influenza vaccine uptake, and a host of response to influenza vaccines and natural infection. So we are in great hands today to explore these two topics. So let me turn this over to our first guest speaker, Dr. Andrus. Good morning, Jon. How are you?
Fine, thank you. Thank you for that great introduction. I'm delighted and honored to be here, and would like to state up front what a pleasure it's been to work the last few years at the Center for Global Health under the leadership of Dr. Stephen Berman, who is the founding director and has really elevated the work there to a global level, making a difference. So I'd like to state that at the beginning. If you're ready, I can go ahead and share my screen with the slide to use.
That would be great.
So I've been asked to provide some perspectives on pandemics and specifically on the COVID-19 pandemic. And I'd like to state up front that many of my reflections are based on my own experience and the bias that brings. Some 35 years ago, my first overseas assignment was to this hospital in Mchinji District, Malawi, where I was asked to be the district medical officer as a Peace Corps volunteer. And although you see in the operating room of a hospital built in 1908 sinks, there's no running water. The windows are broken, flies, mosquitoes come in and out. There's no electricity. So we were operating in field conditions out of the Wild West. And I got a firsthand look of what can work in conditions like this. And I don't think this is unusual in many of the developing countries around the world, at least in those that I've worked in. I had the opportunity to oversee infectious diseases in that district. Measles, we had a measles ward that often would have 2 or 3 patients per bed, and sometimes patients under the bed. Measles is a killer disease. It's the most infectious virus on the planet. And fortunately, we have a vaccine that's one of the better vaccines that we have to offer. So out of this presentation and the discussion to follow, I hope I can leave you upfront with 3 take-home messages: that vaccines in general are the most cost-effective interventions medical science has to offer the public health of the world. As stated as far back in 1993 by the World Bank in the state of the world's health, and they continue to be. That was point number 1. Point number 2 is, however, having said that, not all vaccines are equal. Some vaccines are better than others. This particular vaccine for the most infectious virus on the planet happens to be a very, very good vaccine. And if we use it strategically, based on the evidence, which is my third point to take home, use the evidence, how we use these technologies to make the greatest impact. And in this case, we can actually eliminate measles. It's one of the best buys in public health. Now, polio is another infectious disease caused by a virus, but is not nearly as infectious as measles. Before vaccine was available, this was a photograph of a high school gymnasium in LA County in 1952, the year my former wife actually contracted polio. And it was terrifying to have these conditions where many children had to be put on iron lungs with 24/7 nursing, 1-to-1, to keep them alive. But we have a vaccine. It's not as effective as the measles vaccine, but it does work. And here again, using the strategies and tactics that we know work can actually also eradicate this disease. And we have the experience of the Americas. So going forward with this presentation, I'd like to reflect on some historical aspects of infectious diseases, namely to start with pandemics. Since the start of the last century, we've had 5 pandemics, so far 2 already this year, or this century, with the current one. I would like to acknowledge of those 5 that 1918, by most global experts, is recognized as the mother of all pandemics. It caused the most devastation. And I have to pinch myself sometimes to reflect that I would not be here if my grandfather, pictured there with his two sons, my dad to his right, had not survived the 1918 pandemic while fighting in the trenches in France. So I just am so fortunate that here he was working as a night watchman in the Senate while going to medical school during the day. And he survived, and I'm here to tell the tale. So I feel very fortunate. The pandemic, as you have heard probably in the press and numerous presentations, was devastating. 50 to 100 million deaths worldwide. In the United States alone, there were 675,000 deaths, which was, by the way, 10 times the death rate of the war itself. Just to reflect on how it started in the spring of 2018 because of global movements, but I wanted to highlight what happened in Philadelphia. The pandemic, to some extent, subsided during the summer months, but because of activities like on 28th of September that year, there was a parade, and the parade was to raise funds to fight the war. So, and despite people stating the risk of such a parade, some 100,000 people thronged the streets of Philadelphia. 2 days later, people were dropping like flies, and they ran out of coffins. And price gouging, by the way, is not new. Back then, cemetery prices, the prices of coffins went dramatically up. All this sounds kind of familiar. Fast forward to post-World War II, and I've listed some challenges here that confront the world and the challenges to sustaining global health security, nuclear proliferation, bioterrorism, and the topic we're talking about today, emerging infections. But a cross-cutting issue that I did not mention in the previous slide are natural disasters and emerging infections related to climate change. Here is the 2010 photograph of Port-au-Prince, Haiti, just minutes after the earthquake struck, killing thousands and thousands of Haitians. And then subsequently, the cholera outbreak. And not to mention that besides the 5 pandemics, we've had numerous close calls. Just a few I've listed here. You've all heard about SARS and MERS. And actually, there is a silver lining to those outbreaks because of their contribution to the advancement of science that we're benefiting with vaccine development with the current pandemic. But people don't often know or recognize that in 2004, there was an influenza virus that emerged in South Asia, an H5N1 virus, that only caused 400 cases, but had a case fatality rate of 60%. Think of that. 6 out of 10 people infected died. If that had gone global, that would have been disastrous. And the point here is that authorities used the information and attacked the threat at its source. This virus emerged from poultry, so they went out and they slaughtered hundreds of millions of chickens in order to stop spread of a virus that had jumped to the human host. And with this case fatality rate, the lesson learned is that we really need to maintain strong surveillance, not just in humans, but in animals as well, where these viruses often emerge. And the point of this slide is that it's not always new pathogens, old pathogens that have been around, in this case, dengue, a disease otherwise known as break bone fever, a devastating disease in many situations. These data going back to 1980 showing the almost hockey stick spread, numbers of cases increasing over the years, with the light green being the region of the Americas. And this is a result of climate change, among other factors, migration, urbanization, and so on. But the point is, we have to keep track not only of new pathogens, but old ones that are now on our back door. We've had outbreaks in Houston and Miami of dengue cases, and they disproportionately affect the poor, those homes that don't have air conditioning, screens to prevent the mosquito from the entry into the home. Going forward, just a few messages, and then I'll conclude. Again, the evidence has to be in the driver's seat, particularly for the vaccines that are not equal. They will have different safety profiles. Some will work better than others, but how we use them will be very important. I don't believe we've yet to be fit for purpose, those strategies that maintain aggressive masking in public, aggressive testing programs, contact tracing, and so forth, need to be promoted and used while the vaccine is being developed, and even after the vaccine is introduced, a point I'll get back to. And this is, again, a global problem requiring a global solution that we have not had the leadership, the partnership, and the vision today. So just to end with a few comments about vaccine development. With this slide, there are basically two pathways for vaccine development. The whole pathogen approach is a more traditional approach. We can take the pathogen, kill it, perhaps with formaldehyde or heat. In the case of inactivated polio vaccine, formaldehyde, and then use that as the vaccine. It's a very effective vaccine. Or we can attenuate the vaccine through cultures and other treatments that will soften the virus, still be live, and still elicit an immune response, as in the case of measles, the example I cited previously. The other pathway is the subunit pathway. And what we're learning is that you've heard of the phrase, all roads lead to Rome. Well, it seems that in the vaccine development, taking the subunit approach, that the spike protein is actually critical. And those vaccines that take advantage of acknowledging the influence of the spike protein on the surface of the COVID virus will likely have a greater chance of being useful, of working, and may have perhaps less side effects. But the protein is an example, conjugated vaccine that we see with the pneumococcal vaccine. You can take that protein and attach it to another to make it stronger, make it more effective, particularly in younger children. And the recombinant technology, this is often, I refer to this as a cut and paste technology. You're cutting a viral molecular piece of information, and you either put it in a platform such as yeast cells or attach it to another virus that's benign to allow the coding of that piece of the genetic material to express itself into a substrate or protein that will elicit the immune response. And examples here, the human papillomavirus vaccine is an excellent example, as is hepatitis B vaccine. And then the genetic approaches that are currently being advanced and seem to be out in front, the messenger RNA that you've recently read about in the news. But again, we can't say that all vaccines are the same. They're very different. They'll have different safety profiles and different efficacy, so we have to use the evidence. And so in ending, just to highlight, there are many challenges. I've just listed a few here for you to consider. The documentation of the evidence is absolutely fundamental. In the United States, we have the FDA and the CDC and others working together to document safety and efficacy, but then communicate it so that we maintain public trust. The integration of the tool, the vaccine, has to be with the other public health interventions, masking, contact tracing, testing, and so on, avoiding crowds, all those things that you've been doing and following. It's not a magic bullet is the point. Communication I've already mentioned. And then the vaccine will become available in tranches. It takes about 6 weeks or so to make a batch of the messenger RNA vaccine, And so it won't be available all in one day. It will come out. And so targeting the highest risk groups like the essential health workers, elderly, and the vulnerable people. This virus, COVID, disproportionately affects Blacks, Hispanics, people of poverty, but not just in the United States, around the world. So with my last slide, I'd like to end that these, again, global problems need global solutions. This is a mother I encountered in Uttar Pradesh who is showing me her baby and the vaccination card. You can see the conditions. And these are people that will be most likely to be affected and challenged with the devastating consequences of this virus, as we've seen in Latin America, in various cities and communities in Latin America, particularly indigenous populations. So I'll end there. Thank you very much.
Thank you, Jon. Thank you, Dr. Andrus. A very nice presentation. Alrighty, let's bring in Suchitra to the conversation and presentation, and then after her, we'll go into Q&A. So good morning. Hi, how are you, Dr. Rao?
Hi, Kristan. I'm doing well. Thank you so much. And thank you to you and to the Denver Nature and Science Museum for the opportunity to come and speak with you all this morning. I really appreciated and have listened to a lot of the webinars, and I just love the material and the opportunity to really discuss some of these really important topics with you. So as I share my screen here, let me just pull that up and get that going. Okay, so and also thank you to Dr. Andrus. I have to say I really enjoyed hearing that global and historical context of pandemics, and now we can sort of take some of that information and put it into perspective of what we're seeing now with this current pandemic. So as you heard in the introduction, I am an infectious diseases physician, and I also work as a hospitalist at Children's Hospital Colorado. And I was actually inspired to do influenza research while I was working during the 2009 H1N1 pandemic, and was taking care of a lot of kids that ended up having a lot of really severe complications and illness manifestations from the flu. And I think that there's this underappreciation of just how severe influenza can be, and that it can affect not just people with underlying medical conditions, but it can affect those who are completely otherwise healthy as well. So what I'd love to be able to cover and just to have us all start thinking about is what to anticipate for our upcoming respiratory season when we are faced with our first time of having a COVID-19 pandemic and our influenza epidemic. And to talk a little bit about some of the similarities and important distinctions between flu and COVID-19, and to also think about some strategies that may be effective for mitigating what could happen in the upcoming season. So in terms of what we're anticipating, I think there is certainly a potential to have a severe respiratory season. And one of the most important factors is really going to be the extent of the social distance measures that are going to be in place. I think that we can also see that the healthcare system has already been very overwhelmed. And now we have a situation where there could be both SARS and influenza occurring at the same time. People can get infected with both at the same time. And so I think a lot is to be learned about what things could look like when those things take place. So in terms of some of the predictions that we can make about the upcoming season, I think that some of the factors that are going to really impact that are going to be the extent of social distancing measures that are in place. This is probably going to be one of the most important factors. The next is what the rates are of influenza vaccination. So how well the population is covered against flu and how well that flu vaccine is working for that season. The next is going to be the impact of having both SARS and influenza occurring in an individual and what the impact of co-infection will be. But then also that time period of when both SARS-CoV-2 and flu are going to be circulating. Are we going to see a peak of both viruses occurring at the same time? And if so, then I think that we're really going to be challenged. So when we try and think about influenza, we haven't seen the flu season hit yet. So can we make predictions about when we think the flu season is going to start? And this is something that I'll often say a lot, which is that the only thing that is predictable about the influenza season is its unpredictability. And so to illustrate that, I have a graph here that demonstrates the number of reports of influenza-like illness that goes to the Centers for Disease Control each year. This is looking at the last several seasons. So each season is represented in a different color here. And essentially what I want you to take home from this graph is just that the seasons are really all over the map. So some of them peak early, some of them have a very high peak, some of them have multiple peaks, some of them go away quickly. And so there's really just a lot of variability within a given season in terms of how severe a flu season can be. If we just focus on the last 5 seasons, we know that on average, the flu season lasts for about 16 weeks. And here in the United States, we usually see our peak around December to February. But we have seasons that start as early as, say, November and can go out through as long as May. So it really remains to be seen what our season is going to look like, but maybe we have some clues that might help us make some predictions. So just advance here. So what we have been noticing is we've just been paying really close attention to what's been happening from last season and what's been going on in the Southern Hemisphere. So I just want to take a couple minutes to kind of give you some data on what we've been seeing and how we can make some inferences based on that information. So this is a graph that shows the last flu season when we started seeing cases of COVID-19. So what I want you to focus on for now is just the blue lines. So there are some dotted lines and there are some solid lines. The dotted lines represent the positivity rate for influenza over the last several seasons. And what you see in the blue line is what happened last influenza season. So normally you have this sort of tapering up slowly and then this coming down slowly of the number of positive cases for flu. But what happened last season with COVID-19 coexisting with influenza is you see this really sharp decline in the number of positive cases for flu. And so really that just tells you that once the COVID-19 pandemic was announced and all of our social measures and mitigation strategies were in place, that we had a really sharp decline in the rates of influenza. And so another thing that's really important to think about is just what we've been seeing so far in the Southern Hemisphere and whether we can see any similarities happening for our season. So I'm originally from Melbourne, Australia, and I've been following their season very closely. And so here's just some of their flu data. So this is a graph that's showing the number of notifications to the government in Australia for influenza. And again, you see lots of prior seasons shown in the dotted lines and what happened in the 2020 flu season happening in the red line. So essentially what you can see here is that there has been a complete flatlining in the number of cases of flu over there. It's important to keep in mind that the mitigation strategies that they have been using over there have been a lot more restrictive than what we have been seeing here. So they have had things like longer lockdowns. So Melbourne, for example, just came out of a 16-week lockdown. There have been statewide stay-at-home measures that have been really heavily enforced with law enforcement. There's been a mandatory hotel quarantine of all overseas travel of 14 days and state border closures and things like that. So this pattern has also been observed in some other Southern Hemisphere countries as well. And we're seeing similar data coming out of Chile, South Africa, as well as Argentina. So in terms of what last year's flu season and the Southern Hemisphere season is telling us, essentially, if we do have a further retightening of our social distancing measures, then this has the potential to flatten both the SARS-CoV-2 curve as well as the influenza curve. So now, since we're going to have to think about COVID-19 in the context of flu season, it's really important to think about some of the similarities and then the important distinctions between influenza as well as COVID-19. So unfortunately, there's really no good way of distinguishing the two when you see people presenting with various signs and symptoms. So someone who has the flu, it can look very similar to COVID-19 and vice versa. They're both associated with fever, with cough, with shortness of breath, and some folks can get muscle aches and nasal congestion and headaches, and you can see the exact same things with COVID-19. Now, we've been hearing a lot about COVID-19 presenting with loss of taste and loss of smell, but it is important to remember that loss of smell has been reported for viruses like influenza. And when you've probably experienced, when you have a respiratory illness, that it can impact your sense of taste. So it may not be a great distinguishing feature there either. And then with COVID-19, we have been seeing presentations with people having abdominal pain, with diarrhea, and with vomiting. And that is something that has been well described in influenza as well. I would say more so with children than in adults. And in terms of some of the epidemiology characteristics that are important to think about, the way that flu and COVID spread are actually very similar. So when you have the viruses that are traveling in droplets, you can catch that if you're in close range with someone who's sick. That's really one of the most important modes of transmission. And you can also catch it from surfaces, and then there's some contribution from airborne spread as well. In terms of some other important distinctions, you'll see that the incubation period for flu is much shorter than the range that's being reported for COVID-19. In terms of the contagiousness, we know that COVID you can catch before getting symptoms. You can catch it from someone who's pre-symptomatic and can have it, and you can also be contagious for 10 days afterwards. And then asymptomatic disease, we're learning a lot more about that with COVID-19, with ranges in the literature from anywhere from 5 to up to 43%. Now, you can have asymptomatic influenza as well. It is less common. It's more likely to be seen in children, but it's something that's important to think about too. And something else that's important to really think about are some of the complications that you can get from both COVID-19 and from flu. So one thing that's important for us to note is that with influenza, you're much more likely to develop a secondary bacterial infection compared with COVID-19. So reports of 35% versus say 7%. And those bacterial infections can include things like pneumonia, sinus disease, ear infections in children and things like that, and bloodstream infections. In terms of hospitalization rates, you now well know that people with who are over the age of 65 are at the highest risk of having that COVID-19. That is also true for flu, but remember that it is something that can really cause devastating disease in those who are under the age of 5. In terms of risk factors for infection, there's been a lot of similarities and overlap in the different medical conditions. So for COVID-19, the top conditions in adults are high blood pressure, obesity, diabetes, and heart conditions as risk factors for severe disease. And then for influenza, we do see similar things, but it can also really have a heavy duty impact on those with weakened immune systems and also with neurologic problems. The complications, it's been interesting to see some stark differences there. So we've been seeing more people having clotting complications from COVID-19. The issue of multi-system inflammatory syndrome in children is something reported with COVID-19. Heart rhythm problems and neurologic complications can be seen with COVID. And then for influenza, one of the commonest complications has been muscle inflammation, myositis, as well as neurologic complications like encephalitis, and it can worsen underlying illness like heart failure and asthma, for example. And then what about mortality risk? So this is a summary of a paper that came out recently that was reported from the CDC. And they had looked at the rates of death amongst the folks that were living, this was based on Veterans Administration data, and they showed that there was a 5 times higher risk of dying in the hospital with COVID-19 compared to influenza. So really we're seeing very similar reports from 5 to 7 times more mortality from COVID-19 than influenza. But I really don't want folks to underestimate the impact of flu as well, especially as we're seeing both of these things occurring together for the upcoming season. So just to put some of that into perspective as we think about flu and the flu season, I want to just point out that last season, it was estimated that influenza caused anywhere from 39 to 56 million flu illnesses and resulted in 18 million to 26 million flu visits to a provider. That caused 410 to 740,000 hospitalizations, and it was estimated to have resulted in 24 to 62,000 deaths. So really staggering when you think about those statistics. Now, the other thing I'd like to think about is influenza vaccines and how well they work. And when we talk about effectiveness, what are we really thinking about? So this is a graph that shows you the influenza vaccine effectiveness over the last several flu seasons. And really, on average, our vaccine effectiveness ranges from 40 to 60%. And as Dr. Andrus, and if you were fortunate enough to have listened to Dr. Hotez's webinar not too long ago, I think what this really illustrates is that the flu vaccines are not necessarily going to be able to prevent you from getting the flu, like say the measles vaccine can. But what it can do is prevent you from getting very sick from the flu. And so when you hear about the flu vaccine effectiveness being 40 to 60%, that's really telling you how well the flu vaccine prevents you from turning up to a doctor's office with symptoms of the flu. So let's break some of that down a little bit as we wrap up. So if we want to think about some of these statistics, again, looking at the last flu season, what we can say from influenza vaccination is that it prevented 7.5 million illnesses, which is more than the population of Kentucky and Kansas combined. It was able to prevent 105,000 hospitalizations, and that's enough people to fill Michigan Stadium at the University of Michigan, and also prevented 6,300 flu deaths, which is the equivalent to saving about 17 lives per day over the course of the year. And finally, just to put some of this into perspective in terms of how well it can prevent severe illness, I do want to point out that influenza vaccines can decrease your risk of being hospitalized by about 60%. It can decrease the risk of an adult being admitted to the ICU by 82%. And it can decrease the risk of dying from the flu by 65%. So with that, I will wrap up. So really just thinking through the upcoming respiratory season, I think that one of the most important predictors are going to be just how much in the way of social distancing measures are going to be in place. We talked about some of these very important distinctions between COVID-19 and influenza. And also we learned that and thought about how symptoms of COVID-19 can look very similar to flu, but at the same time, they can really contribute to worse disease. And vaccination, influenza vaccination, while it may not prevent us from getting sick, it can prevent the risk of getting, it may not prevent us from getting the flu, but it can prevent us from getting very sick from the flu. So I thank you for your attention, and we'll take it. Be happy to take questions, and we'll hand it back over to you, Kristan. Thanks so much.
Great, thank you, Suchitra. All righty, we've got a number of questions here, but let me pass this right back to you, Suchitra. Can you have both COVID and flu at the same time? That sounds terrifying.
Yeah, so you can absolutely have both at the same time. And so there have been a lot of reports so far that have been reported worldwide in terms of what we saw earlier in the year. So there was a study that came out in China that looked at a number of folks that were unfortunate enough to have both flu and COVID together. And there was some suggestion that it may lead to worse disease. So those folks ended up being sicker, were in the hospital longer, and had worse outcomes. So right now, it's still a rare event. And so a lot of this is sort of reported to just a few numbers in different studies. And I think we'll learn a lot more about it in this upcoming season. But yes, it is sort of a little concerning that you can have both together.
Jon, let me start with you, and Suchitra, feel free to chime in. We have a lot coming in, of course, as you both could have probably predicted, around the Pfizer vaccine and announcement, including the note that it's potentially 90% effective. I'm wondering if you could comment on this announcement, its potential reliability, and if so, Jon, you had showed some potential, target audiences for, vaccine rollout and development. So maybe start there about the Pfizer vaccine. What is 90% effective? That sounds astronomically high for, looking at some of the flu vaccines. And that target audience, what can we expect from a timeline following this announcement?
My first reaction is it's exciting, but it's preliminary, but it's very exciting. That particular study by Pfizer has some 44,000 study participants, which is a fair number. It's too early to say that there might not be a rare adverse event that you would see later. Even after starting vaccination on a mass scale, you would need to monitor the safety profile. Adverse event monitoring that we call will help define that and to communicate it to the public to maintain trust. But I find it exciting. They reported some 94 infections, only 9 or so in the vaccinated group. That is the group that received 2 doses. The genetic vaccines have some operational challenges. I mentioned that in the deployment. So I happen to sit on the advisory board of the Ministry of Health Mexico, where they're looking at the various vaccines that may be available for them. And the messenger RNA is one. And they've been reviewing what would it take to have a successful distribution of this vaccine. Well, you need a storage, you need a cold chain that is able to maintain it at 80 degrees Celsius, below zero. And so you would need dry ice and other measures they find quite challenging. It's not to say they can't do it, perhaps target cities, perhaps target the healthcare workers first. But the bottom line is that it's very exciting. We still need to keep our vigilance on and monitoring the safety concerns that may evolve.
Yeah, Kristan, I would just mirror exactly what you heard from Dr. Andrus in terms of this being very exciting and early information. We know that the FDA, when they were coming up with sort of their requirements of what would be considered an effective COVID vaccine, that they set a bar of 50%. So to see data that really well exceeds that to 90%, I think is certainly very interesting, exciting information. And it's important to keep in mind that there will be these early data that come out where you sort of have these interim analyses showing what the effectiveness is at preventing infection. And I think that over time, these phase 3 trials are really designed to look at some of the safety things that we will need to know over time. So after a vaccine is administered to these trial subjects, we need to make sure that over months that follow that folks continue to do well and feel well. And so even though we get these sort of early preliminary data, I think it's important for folks to recognize that this is something that they are going to continue to look at and evaluate even a couple of years after initial enrollment.
And so Linda commented that she got her 65 plus flu vaccine in mid-September. Is she going to need to get her booster in 4 months?
Yeah, that's a great question. I'm so glad this came up. So what some data has been suggesting is the issue of waning immunity. So we know that influenza is very tricky, that the virus can mutate, that your antibodies that you develop may not last for the entire year, and they can go down over time. And we do notice that this is something that can happen more in folks that are 65 years and older. And so if you get a flu vaccine, say in July or August, that may be too early. If you get a vaccine in, say, September, we know on average it lasts for about 6 months, and that should protect you for the flu season. We also know that that issue of waning immunity happens more with the influenza A strains, which typically happen at the beginning of a season, compared with influenza B strains, which happen more towards the second part of the season. So that all kind of means that we have those odds that we'll have good protection. And then for those who are over the age of 65, it's good to get those vaccines that are really targeted to that age group, so the high dose vaccine and the adjuvanted vaccines. So that will confer better protection and will probably potentially also mean that you have sort of longer lasting immunity over the whole season.
Thank you. Jon, could you talk a little bit about how important collaboration is with the World Health Organization?
Well, my short answer, it's absolutely critical. The US entities such as the CDC are globally recognized as being models of public health institutions, and to not have those dedicated workers at the table with other global experts is kind of like fighting the battle with two hands behind your back. You're not attending the meetings, you're not privy to some of the early discussion of results. And so it's fundamental. And these viruses don't respect borders. So being able to collaborate among countries is also critically important. The global interrelation and relatedness of these diseases is obvious. And for us not to be at the table is very sad. As the former deputy director of the Pan American Health Organization, one of my jobs was to go up to Capitol Hill and brief Congress people and their staff about the work that the Pan American Health Organization does, which is the regional office essentially for the Americas for WHO. And I never asked for additional money that would turn people off. But what I did was I framed it. Imagine a world without the Pan American Health Organization. Teddy Roosevelt was the leading cause and advocate of its foundation back in 1902 to tackle the ravages of yellow fever. So imagine a world without PAHO, and you can go back to the measles example, where before measles was eliminated in the Americas, most all the cases that were imported were from Latin America and the Caribbean. And now that has been taken care of. So it benefits us. And if you look at the economic arguments as well, it's a tremendous value-added organization that the US is a fundamental member of.
Thank you. We are coming up on our time, but I want to end with one final question that I asked you both to speak to, because it's going to be around communication and trust. And so I'm going to try to combine 3 different audience members' questions here from David and Michelle and Lindsay into kind of this big picture. And maybe Suchitra, you can start, and Jon, you can also comment after that. And it's around, again, misinformation, rumors around the COVID vaccine, but as well as the flu vaccine. So I'm actually going to take Lindsay's question and frame that, which is, Lindsay is a public health worker, and she's struggling with what she's seeing as deep resistance, mistrust around flu shot uptake around specific populations. But I'm assuming we are seeing this a lot around a lot of different populations, particularly vulnerable populations for COVID. What can any public health provider do, or what can anyone do to understand and drive that increased rate to dispel myths and misinformation, and to really communicate truth around the safety, the effectiveness, the need, and the reliability of vaccines, including both the flu shot and COVID, and how people have concerns that she specifically have heard that if they go to get the flu shot, it's scientists trying to trick them into getting the COVID shot, which has, we've seen in public polling results, there's, some trust around the COVID vaccine, but, I know we have challenges with that with the flu vaccine too. So that is a really big question, but in essence, it's around, how do we dispel any sort of rumors? How do we instill trust with either our patients or other audiences when it comes around the need to get vaccines? Suchitra, would you want to start, and Jon, close out for me, please? Thank you.
Yeah, sure, Kristan. Thank you for asking that question. It is so vitally important, and you're right, it's such a huge topic, and we could spend another hour talking about this and some of these strategies. I think that this is really becoming a huge issue where we have technology that's getting better and better. We have vaccines that are doing better. And, as you've seen historically, vaccines are really a public health celebration. Things that have worked, that they're effective, and that they save lives. And unfortunately, a lot of the messages that we as people who work in public health have been, I think they've been overshadowed by this anti-vaccine movement, this group that's sort of propagating a lot of myths and just untruths about vaccines. And so I think that unfortunately they will often be these very vocal people. And I think we as a scientific community and as a well-read community really need to do everything that we can to also be vocal about the importance of vaccines and about how safe they are. And I think to be fully transparent is really important as well. So you've seen a lot of communication around that as folks are developing the COVID-19 vaccine. They really want this to be a very transparent process to really make sure that the public is aware that, yes, we're looking at the effectiveness of the vaccine, but we're also making sure that this is going to be safe and that this is something that we can, sustain because of that safety. So I think just to break down that question a little bit, I think there's a few different things that we can do. So I think one is to make sure that the scientific and medical community all have that information that they need to make sure that we can still continue to make a strong case for vaccines and how they work and the safety. I think second is things that you're doing, Kristan, you and your group, to really give opportunities for us to present our side. Because like I said, you can sometimes just be overwhelmed with the amount of sort of mistruths that are coming out from the anti-vaccine movement. And then I think also it's really important for people to just ask those questions. This is what I'm concerned about. This is what I've read. Talk to your medical community and get those answers. Like what's the real truth here? How can I find out more? And then when you do realize something is truth and that's something that you can get behind, I think just encouraging others to really have that shared vision that really this shouldn't be something that we need to be debating. Vaccines work, they're effective, and they're tested extraordinarily well. So I think those are my sort of initial thoughts, and I'm happy to chat more about the subject, but I'll pause here for now.
Thank you. To add to Dr. Rao's comments, look at it, there are multiple ways of looking at this, but I would simplify it looking at it at two approaches. The provider approach. People generally have a lot of trust in their primary care provider. Dr. Sean O'Leary at the University of Colorado is doing a lot of research on how to communicate to patients, and he's emerged as a global leader on this. So his approach of being presumptive, proactive with your message as the patient enters the room, you say, hey, it's great you're here for your vaccines today, rather than what can I do, that more an open-ended traditional approach. You're sort of setting the table, getting them involved, and people generally follow norms and they'll listen to their provider. They trust them. The other is the public health approach. I, in a former life, worked on polio eradication in India, and I'll never forget going to Nepal. I worked in India and a number of other South Asian countries, but in particular going to Nepal and seeing this billboard, and I asked my colleague to translate it. It was a person on a motorcycle with a leper, a clear leper. If you know, for those that have seen leprosy, you see this facial disfiguration, and I could say, that's a leprosy patient hugging this person, and that happened to be the most famous comedian in Nepal, to show to the public you don't have to fear leprosy. It doesn't have to be stigmatized, because people were not going to clinics that were treating lepers, and they were trying to destigmatize this with these messages that was actually being funded by the BBC. So you can take advantage of community leaders. It may not be me, Jon Andrus, giving the message. That shouldn't, in fact, that may be counterproductive. But if you get Muhammad Ali when he was alive, or Willie Mays, or this famous comedian, you get those people involved, people will tend to, follow the norm. They did a study in college students that those that took the meningitis vaccine were more likely to take it if they knew the other students were taking it. So those are kind of some of the strategies I think will help benefit us as we go forward.
Absolutely. Thank you. Those are great tidbits of takeaways for today. So I appreciate you all both tackling that really big question that we hear over and over in almost every episode. So there's lots of strategies, and I appreciate those perspectives. Thank you both for your time today. This was an absolute pleasure. You had a great amount of wealth and information. So thank you for bringing some of that to our audience today. A huge thank you to our audience as well. We had great questions. I did not get to all of them as to be expected, but we see them and we're really appreciative of you chiming in, and thank you for joining us. Like I mentioned, we'll be back here on December 14th. So we do have a small break. We will miss all of you in that break, but definitely, keep involved with us in the interim, follow us on social media. Keep updated, stay vigilant as we roll into the flu season here, and with COVID as well, really seeing some surges in cases happening here in the state of Colorado. So please stay safe and stay healthy, and thank you all for joining us. And we look forward to seeing you again on December 14th. Have a good day.